Good afternoon. This is Neil Amari-Rish, and I'm the Director of the National Eye Health Education Program, and I'd like to welcome you to our webinar, Advances in the Treatment of Diabetic Retinopathy, Paradigm Shifts in Patient Care and Education. Joining me this afternoon are my esteemed colleagues, Drs. Emily Chu and Judy Kim. Dr. Chu is the Deputy Director of the National Eye Institute's Division of Epidemiology and Clinical Applications. Her areas of expertise include retinal diseases, diabetic retinopathy, age-related macular degeneration, clinical trials, epidemiology, and nutrition and vision. Dr. Kim is a professor of ophthalmology at the Medical College of Wisconsin and has expertise in vitreoretinal diseases and surgery, diabetic retinopathy, and age-related macular degeneration. She also serves as the vice chair of the Diabetic Retinopathy Clinical Research Network, which you'll be hearing more about shortly, and is a member of the National Eye Health Education Programs Planning Committee, which is our advisory board. Diabetic retinopathy is an important topic because it's currently the leading cause of vision loss and blindness in the U.S. among working-age adults. And for the first time in decades, there are newer and better treatments available. We'll be discussing what diabetic retinopathy is, how it affects vision, what we've learned from past clinical trials and medical therapies, key findings from the recent trials from the DRCR-NET, and what they mean for clinical practice and patient care. We'll also be talking about some free patient education resources to help you talk to patients about diabetic retinopathy. In case you're not familiar with the National Eye Health Education Program, or what I'll be referring to as NEHEP moving forward, we're the education arm of the National Eye Institute at the U.S. National Institutes of Health. We are established to serve as an extension of NEI's activities in vision research so that science-based information can be applied to preserving sight and preventing blindness. We have several program areas, which include focuses on diabetic eye disease, glaucoma, low vision, age-related eye diseases, and special population outreach. And our goal is to translate eye and vision research into public and professional education programs. To help provide the latest research about diabetic retinopathy, we'll be sharing information from the NEI-funded Diabetic Retinopathy Clinical Research Network, which is a collaborative network of more than 115 sites, more than 400 physicians throughout the United States. We're dedicated to facilitating multi-center clinical research on diabetic retinopathy, diabetic macular edema, and associated conditions. Its emphasis is on clinical trials. However, epidemiologic outcomes and other research may be supported as well. So before I pass the slides on to Emily, I want to set the stage a little bit. Rates of diabetes in the U.S. are high. And as you'll see here, 29 million Americans have diabetes, which is close to 10% of the population. 8 million people have it and don't know it, and an estimated 86 million adults have prediabetes, and 1 in 4 of them don't know. These numbers are high, and as we all know, it's extremely important for people with diabetes to control their disease to prevent complications like diabetic eye disease. Diabetic retinopathy is the most common type of diabetic eye disease, and it damages the blood vessels in the retina, the light-sensitive tissue in the back of the eye. The photos here illustrate what vision may look like for someone with advanced diabetic retinopathy, and the black splotches you see there are from leaking blood vessels. Among U.S. adults age 40 and older, diabetic retinopathy is estimated to nearly double over the next 40 years, so you'll see this is a growing public health problem. And as this slide shows, the prevalence is on the rise for all major racial and ethnic groups in the U.S. We know that diabetes can be controlled, and there are things people can do to delay the onset or progression of retinopathy. And I'm going to turn things now over to Emily, who's going to provide a more in-depth interview of the disease. So, Emily.
Thank you. Thank you, Neil. Welcome, everyone. It's my job first to explain to you what diabetic retinopathy means. I'm going to do this in the next few slides and show you some of the things that we've been done in the past decades that we've done in research supported by the NIH. The so-called early treatment diabetic retinopathy study classification has been a classic standard of treatment that we use for designing clinical trials. And these are done looking at fundus photographs, which are taken of patients with diabetic eye disease or diabetic retinopathy. I will now speak a little bit more about how this happens. There are 5 pathological processes that actually occur. The first is the formation of microaneurysms, or these outpouchings of the small blood vessels in the eye. So the complications from diabetes has to do with the very small blood vessels in the eye, in the kidney, and also in the peripheral nerve. So and focusing back on the eye, as the disease progresses, we have this excessive vascular permeability, which is clearly the leakage of the blood vessels. Blood vessels normally are like pipes that do not allow anything to leak through, but with damage and with disease, the leakage occurs. And with time, these blood vessels actually occlude or they close, so there's actually a lack of blood going to the area that it serves, and there's a lack of oxygen. And that's, the body somehow kind of makes up for it by developing new blood vessels that are abnormal. They can cause hemorrhage, and with the contraction of these new blood vessels, you can get scarring and retinal detachment, which is really a terrible end stage of macular disease, retinal disease. And here's the first sign of the disease, microaneurysms. You can see with the arrow, there's some red spots there. These are outpouchings of blood vessels that come and go. And at this point, there's minimal impact at vision. Patients may be 20/20 and have no idea they have diabetic retinopathy. However, with the blood vessels leaking more, it causes a swelling in the center of the macula, the retina, what we call macular edema. And it's like the film in the camera. It has to be nice and flat, but when the film is swollen, it doesn't work very well. And the first signs of that are those yellow hard exudates you see with the arrow. Those are mainly lipids that leak out of the blood supply and cause damage to the retina. This is so-called macular edema, and that's one of the causes of vision loss, a swelling of the retina. And this can be treated, and we'll speak some more on the treatment. One of the ways for diagnosing this is with a fluorescein angiography, which is a dye injected into the arm, and we take graphic photographs of the eye. On the left, you see a picture of the normal macula where none of the blood vessels are leaking. However, on the right side, the macular edema that's swelling the eye, you see a lot of white coloration there. That's from the leakage of the dye into the macula, and this eye is diseased and has vision impairment. As the blood vessels occlude, we actually can look at the retina and recognize this. There are more hemorrhages, as you see a lot more red spots in this photograph on the left. And on the right, you see the sort of sausage-like beading, so-called venous beading. These are abnormalities that we recognize as this eye is going to more trouble. And these are abnormal blood vessels you see, which are pre-existing vessels, and we have a name for them called IRMA, intraretinal microvascular abnormalities, which are not the true new vessels that we'll see later, but this is a sign of very poor control and poor oxygen in that area. So this leads to the more dreaded cause of vision loss, and that's the new blood vessels, or proliferative diabetic retinopathy. And here we see what we call a high-risk case where the new vessels are on the optic nerve, in that yellow round spot you see, and you see a line of hemorrhage. So this patient is at high risk for developing vision loss. And this eye has been well treated with laser, could do very well. And here is a case of the new vessels that is not on the optic nerve but elsewhere. If you see, laser spots are put in on the right photograph, and those nevascularizations show up quite well. So you can have new vessels on the nerve or elsewhere. But nevertheless, they can bleed and cause damage, and also can contract and cause more damage. So the blood vessels can be quite extensive, as you see on the photograph on the left, what we call advanced proliferative retinopathy, lots of new blood vessels shown by the arrows there. In the right, these are contraction of the scar tissues. In other words, the normal tissue is being pulled up and contracted into perhaps retinal detachment, or it can cause bleeds, and this can be damaging to the vision. So this is the clinical classification. I want to talk about the global burden of diabetic retinopathy, and then talk about some of the clinical trials that were done prior to the DRCR, Diabetic Retinopathy Clinical Research Network, that Judy's going to talk about, and then finish with the medical therapies, which are very important for our armamentarium for helping our patients with diabetic retinopathy. So as Neil has said, the burden of diabetic retinopathy is quite immense. Globally, coming from 35 studies in which we had 22,000 participants that were looking at this study, about a third of them actually have diabetic retinopathy. That's 93 million people globally. 7% will have this proliferative disease, this new blood vessels that we talked about. About 7% will have diabetic macular edema, and altogether 10% may have the combination. This is what we call vision-threatening diabetic retinopathy, either the swelling of the macular edema or the new vessels growing. And some of the risk factors we found, the longer the duration of diabetes, the more likely you're going to have diabetic eye disease, and also poor sugar control, poor blood pressure control, and even control of blood cholesterol is very important in terms of keeping the eyes in good shape. So this is a graph of all the things that we've done in the NIH in terms of the different studies. I'm going to speak from some of these studies that have been done for a number of years now in terms of treating diabetic retinopathy. On the top, you see a scale going from no retinopathy to more severe retinopathy, and each of these individual studies basically covers that aspect of retinopathy, from the very mild retinopathy to those with high risk of retinopathy. And there are a number of alphabet soup, but I'll go over these very quickly with you in depth. So the standard treatment for diabetic retinopathy has been laser photocoagulation, also surgical intervention when you have scarring or hemorrhage, and the medical therapies, which are in gray here, will be covered by Judy. These are treatments that are delivered right into the eye with injections. And finally, we'll talk about systemic medical therapies, which involve blood sugar control, blood pressure control, and cholesterol control. The first study that's been done was the DRS, the diabetic retinopathy study, done in the 70s, which proved that laser photocoagulation can reduce the risk of severe vision loss, that's very poor vision on 2 occasions 4 months apart, by 50%. And this was revolutionary. Before that, patients who had diabetic eye disease were destined to be blind by 5 years, and most of them had seeing eye dogs, and that certainly has changed dramatically. And this is what it looks like. The lasers are done immediately. After laser, you see in the picture on the left. On the right, those are the laser scars a year later. This patient retains 20/20 vision because of the laser photocoagulation. This slide shows the untreated part of the DRS, which is the study we just talked about. Another study, which is called the Early Treatment Diabetic Retinopathy Study, ETDRS, shows that this risk of severe vision loss is reduced even further to by 95%. So this laser is highly effective and very important in treating patients with diabetic retinopathy. We also found in the 80s that focal treatment using laser to the areas of leakage for macular edema was also important in reducing the risk of moderate vision loss by 50%. And this is a picture showing what we did in terms of the study. On the left, where the prior to laser, you see the yellow spots, those hard exudates that we're looking at. It's very pathognomonic or very representative of macular edema. But when you see immediately right after laser, those white spots that are delivered are the laser burns. And 4 months later, the hard exudates, yellow spots are gone, and the laser is barely visible in this case. So this became the standard therapy in 1985. And Judy will tell you some more treatments that we've developed since then, but this still remains a very important part of our treatment. And for those patients with scarring and hemorrhage, vitrectomy is an insertion of these micro instruments under microscopic examination for removing this scarring and also the hemorrhage. And here's the case where the patient had a lot of scarring. This picture on the left is before surgery, and post-surgery you can see that the eye is restored to its normal anatomy. This is all the same as this patient was severely impaired because of the hemorrhage in the eye. And again, before and after surgery, you can see that you can recognize the eye formed after the vitrectomy, as well as the scar tissue. So these are indications for vitrectomy, which is for the very severe end of the disease. We'll turn our attention now to medical management, looking at glucose, pressure, and lipid management. One of the landmark studies was done in 1980s called the DCCT, Diabetes Control and Complications Trial for type 1 diabetic patients. These patients could either have no retinopathy at baseline, the so-called primary prevention group, versus those who have retinopathy at baseline, the secondary prevention group. They were randomly assigned to having very intensive blood sugar control versus the conventional. So when we did that, we found that we could separate out their A1C levels, and we wanted to know whether we could prevent development of retinopathy and subsequent progression of retinopathy in those who didn't have retinopathy. Those who already have retinopathy, is it too late? Can we prevent it from progressing? So with that, we were able to separate the A1C levels. The intensive group had A1C levels around 7, and whereas those in the conventional group around 9. And if we go further, we can see that these are the results of the study. And those who had no retinopathy, the primary intervention, you can see that the yellow represents the progression of retinopathy, the worsening of retinopathy over time, and this over a period of 8 years. With the intensive group, the rate is much lower. So there's a large treatment effect in reducing the risk of progression in those patients who had no retinopathy. And that's also true of patients who already have retinopathy in their eyes. So it's not too late. The horse is not out of the barn. You can actually still treat when you have retinopathy. You can see that this treatment effect, the yellow conventional group, has a lot more higher rate of progression of retinopathy versus those who are in intensive group. So we found that the reduction of retinopathy is reduced by as much as 34 to 76%. No drug can do that for you. So the importance of treatment with good glucose control cannot be underestimated. Photocoagulation is reduced by about a third, that's laser, and the first appearance of any retinopathy is reduced by a quarter. So these are very significant findings for patients with diabetic retinopathy. It's also good for the kidneys. It reduces the risk of kidney abnormalities as well as neuropathy. The nerves that enter your hands and feet, and they certainly can be reduced as well with good control. What is astounding about this is that this study stopped, the clinical trial stopped. We were able to follow those patients for another additional 25 years. And with that, you can find that even after that short period of time of tight control, patients still persistently had effects, beneficial effects 25 years later. Patients had less cataract surgery, less vitrectomy, less laser, so that this is a very enduring type of treatment. So that was for type 1. For type 2, we're able to show very similar findings in patients done in the United Kingdom prospective diabetes study, again done in 1977 to 1994. You can see that this is a tight control of glycemia and blood pressure control. Again, we found beneficial effect in these type 2 diabetics that by having very good blood sugar control, reduce the risk of all microvascular complications, which is the kidney and the retina, and progression of retinopathy reduced by 25%. And the blood pressure control, which was 140 versus 180, which is very high for now, because in those days it seemed like that was a reasonable thing to do, but even 140 is seen to be high in the current treatment. But nevertheless, this amount of blood pressure control reduced the risk of all the retinopathy and complications by significant amount as well. And interestingly, this so-called metabolic memory, this legacy effect, the fact that this persistent effect continues on even 10 years later, the self-reports of hemorrhage or laser photocoagulation or kidney failure was reduced by 24%, 10 years later after the study had stopped. So again, this is a very enduring type of therapy. We now talk about the actions to control cardiovascular risk in diabetes, the CORE study. Again, in type 2 diabetes, and more currently, finished in 2009, we had 3 medical therapies, blood sugar control, as well as blood lipid control and blood pressure control. And we went down the glycemic control to a very low level, less than 6, and blood pressure control, you can see, is 120 versus 140. And for the cholesterol control, we looked at fenofibrate, which was used to see whether it would improve retinopathy as well, or reduce the risk of progression. You can see here the A1C levels during the course of the study was nicely separated out, so those with intensive group had maintained a very good level of around 6.3 or so, and the standard group was at least 1% higher, so clearly there was a difference between the two groups. We went in and did eye exam at baseline in 4 years. We did the fundus photograph that I showed you earlier. We want to look at the progression according to this. We can find that glycemic control had a odds rate of 0.67. Anything that's less than 1 means that it's actually beneficial, and the fact that 95% confidence interval did not include 1. So both the glycemic control and the lipid therapy with fenofibrate were highly significant, as you see by the p-values, but blood pressure did not make much difference, at least going to 120 versus 140 was not particularly influential in any way. So when we looked at the intensive glycemic control and the fibrate treatment, you can see reduced the risk of retinopathy progression by about 1/3. We had no effect on visual acuity, and again, no effect on by blood pressure control. And what's interesting is that as we went on, we came back at 8 years after the study had finished. Again, we found that glycemic control persisted. So just a short period of time of less than 4 years of duration of blood sugar control was able to maintain almost a 50% reduction 8 years later. So that is very important for us to consider for all our patients. The lipid effect went away because we stopped the fenofibrate, so the fenofibrate may be very important, and further studies are being done in that arena. So with that, I'm going to just summarize saying we have very highly effective therapies from evidence-based studies. The medical therapies are extremely powerful and very durable. The treatments using the standard laser reduce the risk of severe vision loss dramatically, and laser treatment remains an important part of the therapy. However, we have many other things to offer you, and Judy will now tell you the new treatments that we've been working on, and thank you very much again. Judy?
Thank you. It is my pleasure to present to all of you some exciting new study results that are changing our current management of diabetic retinopathy, in addition to what Emily has already nicely gone over. We will review findings from the 3 pivotal multi-center clinical trial findings from the Diabetic Retinopathy Clinical Research Network, or DRCR-NET for short. These trials are Protocol I, T, and S. Some of you may ask, what do these letters I, T, and S stand for? Well, it is actually simple. The DRCR-NET clinical trials are named by alphabet starting with letter A. What happens when we run through alphabet? We now have Protocol AA that is ongoing, and the Protocol AB is currently being developed. So, we'll go over these 3 pivotal studies, and then we'll wrap this portion with a summary of what the paradigm shift is. As we have just heard, for many decades, laser photocoagulation has been the standard of care for diabetic retinopathy. For proliferative diabetic retinopathy, the pan-retinal photocoagulation was the standard of care based on the diabetic retinopathy study from the 1970s. And then for diabetic macular edema, focal grid laser treatment was the standard of care based on the early treatment of diabetic retinopathy from 1980s. And the lasers are still being used. However, there have been, in my opinion, 2 important discoveries that have aided in changing the paradigm to the current level. The first, in my opinion, that has been very contributing to the improvement of management of diabetic retinopathy is the development of optical coherence tomography, or OCT. This is a fundus imaging capability that allows us to see actually the retina at the macula here, as seen on the slide, with the amount of retinal edema seen as the swelling within the retina, as well as swelling with the fluid accumulation under the retina. Using this OCT technology, we can actually measure, quantify how thick the retina is, as well as see the location of the macular edema. So now that we have this objective way of documenting the amount and the location of retinal edema, we can use that in clinical trials to see whether a therapy is beneficial or not. And also we use it now in the clinic to monitor the response to therapy. The second innovation that I think has contributed to our new paradigm shift is the discovery that vascular endothelial growth factor, or VEGF for short, was elevated in eyes with active proliferative diabetic retinopathy and in eyes with diabetic macular edema. Now, VEGF mediates or allows growth of new blood vessels and also causes damaged vessels to leak, or has a vascular permeability effect. Since these 2 things happen in diabetic retinopathy, new blood vessel growth and leaky vessels, they were natural targets for therapy for diabetic retinopathy, as well as other retinal vascular diseases. Currently, there are 3 anti-VEGF drugs that have been developed and are in the market. These are Avastin, otherwise known as bevacizumab, which is a generic name, Eylea, or aflibercept, and Lucentis, otherwise known as ranibizumab. Since the generic names are quite mouthful to say, and most of you are more aware and familiar with the brand names, I'm going to be using brand names as much as possible in my talk. Laser photocoagulation is performed in the office, and it is still being used to treat eyes with diabetic retinopathy. Anti-VEGF agents are injected into the eye, also performed in the office in the United States, while it may be performed elsewhere, such as in a procedure suite or operating room in other parts of the world. The eye is prepped with povidone iodine, which is seen as this yellowish change seen on the eye, which is an antiseptic to prevent infection in the eye. And you also see in this slide that a lid speculum is inserted, which opens the eyelids wide and pushes the eyelashes away from the injection site. All these are done in order to prevent complications such as infection that can occur during injection of anti-VEGF agents. One of the greatest strengths of having collaborative networks such as DRCI-NET is that we have many investigators and study sites throughout the United States, and we now even have sites in Canada. Therefore, we can enroll a large number of patients in a short period of time, which gives significant power to the results of the study, and we can do types of studies that are not possible at a single center. Also, the studies are rigorously monitored for scientific accuracy and patient safety. Now let's start with Protocol I. At the time when this study was designed, focal grid laser photocoagulation was the standard of care for treating eyes with clinically significant diabetic macular edema. Also, some small studies seem to indicate that steroid injection into the eye may control the diabetic macular edema. However, steroids have known side effects such as pressure of the eye going up or cataracts developing. And we wanted to find ways to improve vision more than what laser was able to do. Therefore, an anti-VEGF agent such as Lucentis was tested with or without additional focal grid laser treatment to see whether that can show improvement that was not seen with the other two treatments. So in Protocol I, the objective was to evaluate the safety and efficacy of intravitreal anti-VEGF treatment in combination with immediate laser at the baseline or deferred laser and intravitreal corticosteroid in combination with laser compared with laser alone in eyes with center-involved diabetic macular edema. Eyes with diabetic macular edema involving the center of the macula by optical coherence tomography with center field thickness greater than the normal and vision 20/32 or worse were eligible for the study. Between March of 2007 and December of 2008, total of 691 subjects with 854 eyes at 52 sites were enrolled in this trial. So what did the study find? At year 1, which is seen on the dotted line, the 52-week mark, and at 2 years, which is circled in red in the slide, the laser alone group or the steroid plus laser group showed improvement, but only about 3 letters. In contrast, the Lucentis group, the anti-VEGF group with prompt or deferred laser at 1 year, shown on the dotted line, and at 2 years, shown on the circle, showed even more improvement in vision, and this improvement was statistically significant. This improvement in vision in the Lucentis-treated groups with prompt or deferred laser was carried out even through the 5 years of the study, and between the two groups, whether they got laser or the laser was deferred, there was no difference in final visual acuity at 5 years. This was not statistically significant. The interesting thing that was found during the study was that the median number of injections continued to decline over the 5 years, such that the number required to improve vision in the first year was 8 or 9. Then this dropped precipitously to only needing 2 or 3 injections. And by year 3, median number was 1 or 2. And in years 4 and 5 of the study, the median number was 0. Over half of the eyes do not require any additional injections. This is important because that means that if we treat patients aggressively in the beginning, early on, with injections, then we may be able to maintain this good vision even with less number of injections later on. Now, this is in contrast to other diseases such as age-related macular degeneration that requires continuous frequent number of injections. So what has been learned from Protocol I for diabetic macular edema treatment? We found that intravitreal anti-VEGF agents such as Lucentis with or deferred laser is more effective in increasing vision compared to with laser or steroid with laser in eyes with diabetic macular edema involving the center macula. Vision benefit from intravitreal Lucentis was maintained for up to 5 years of follow-up, and the number of injections that were required continued to decline in each year of the study. Therefore, intravitreal anti-VEGF agents such as Lucentis should be considered for patients with diabetic macular edema and those who have decreased vision. And this has helped to define the paradigm shift and has now become the standard of care for eyes with diabetic macular edema with decreased vision. What about Protocol T? Well, Protocol T came about because of a couple of issues, and I'm pleased to share with you the most recent year 2 data of the study that was published in June of 2016 in ophthalmology. So, Eylea and Lucentis both are FDA-approved, Food and Drug Administration approved for diabetic macular edema treatment and can be used in the eye. However, Avastin was actually developed for treatment of cancer. Therefore, it is not approved by FDA for use in the eye. But when we put a small aliquot, 0.05 cc's, into the eye, we found that it can have beneficial effects for diabetic macular edema. So people in the community were using it. Also, there are significant difference in the cost of these medications. Eylea and Lucentis are expensive, while Avastin is 1/40th of the cost of these 2 drugs. And given the issue about medical costs and healthcare costs rising, this can be an interesting study to look at that as well. So in Protocol T, we looked at efficacy and safety of intravitreal Eylea, Avastin, or Lucentis in eyes with central-involved diabetic macular edema with vision decrease between 20/32 to 20/320. 660 eyes from 89 sites were equally randomized to each of these 3 groups, and there was head-to-head comparison in a pairwise fashion. Injections were given every 4 weeks until the eyes were deemed stable. And starting at month 6 visit, laser treatment, focal grid laser treatment can be administered if macular edema persisted and was not improving. So, what did the study find? The study found that, again, just like in Protocol I, the number of injections required over 2 years continued to decline, such that in year 1, all 3 groups required on a median of 9 or 10 injections, while the second year, the number required was 5 or 6. And the laser treatment that was required for the 3 groups was slightly less in the Eylea group compared to the Avastin group, such that at year 2, there was a statistically significant difference between number of laser treatments required between Eylea group and Avastin, with Avastin group needing more laser at 64% compared to 41%. How about the visual outcome? This is for the whole group, regardless of what the baseline visual acuity was. What the study was that found was that all 3 groups showed visual acuity improvement, both at year 1 with 13, 11, or almost 10 letters, and year 2, 13, 12, or 10 letters in each of the Eylea, Lucentis, and Avastin groups, respectively. Interestingly, when the cohorts were looked at based on their baseline vision of mild vision loss, 20/32 to 20/40 versus 20/50 or worse, there was a very interesting finding. It happens that half of the study eyes had 20/30 to 20/40 vision loss, and at 1 year and at 2 years, all 3 drugs improved vision to be around 7 to 8 letters of improvement from the baseline. However, when we looked at eyes that had more significant vision loss at baseline, 20/50 or worse, at year 1, Eylea seems to be more superior in improving vision. In fact, almost 19 letters were improved compared to 14 letters in Lucentis and 11 letters in Avastin. At year 2, 18 letters were improved in Eylea group and 16 letters in the Lucentis group and 13 letters in the Avastin group. It turns out with the statistical analysis, at year 2, both the Eylea and Lucentis group were similar in improving vision, and Eylea was still better than Avastin in terms of improving vision. So what did we learn from the Protocol T for managing diabetic macular edema? We found that all 3 anti-VEGF agents are excellent. whether they had additional laser or not, in improving vision in eyes with center-involved diabetic macular edema with vision loss. However, based on the study, it appears that depending on the initial visual acuity, we may want to consider different anti-VEGF agents, with Eylea and or Lucentis being more superior for worse vision at baseline. And then finally, let's go over DRCI-NET Protocol S. This is now for proliferative diabetic retinopathy, whereas the other two were for diabetic macular edema. Currently, the treatment for proliferative diabetic retinopathy is pan-retinal photocoagulation. However, laser treats with heat, and therefore it is thermally destructive. When pan-retinal photocoagulation is placed around the periphery of the retina, it can cause visual field defect, side vision loss, or night vision decline, or sometimes even central vision loss with increase in diabetic macular edema. Now, based on the other two studies that I just talked about, the standard of care for diabetic macular edema, whether the eye has proliferative diabetic retinopathy or not, is anti-VEGF as first-line treatment. So what if we treat eyes with anti-VEGF agents such as Lucentis for managing proliferative diabetic retinopathy? In this study, the objective was to determine if visual acuity outcomes at 2 years in eyes with proliferative diabetic retinopathy with or without concurrent diabetic macular edema that received anti-VEGF agent therapy such as Lucentis with deferred pan-retinal photocoagulation are non-inferior to those in eyes that receive prompt pan-retinal photocoagulation therapy. So I underlined non-inferior there. So the other two studies were superior endpoint studies, seeing which agent or which treatment modality improves the vision more. In this non-inferior study, there was a predefined letter score of plus or minus 5 letters. So if the Lucentis treated group ended up within plus or minus 5 letters of the pan-retinal photocoagulation group, then the study finding would show that the Lucentis treatment would be non-inferior. If Lucentis group did not come close to 5 letters to the pan-retinal photocoagulation group, then it would be deemed that the anti-VEGF therapy would not be beneficial for treatment of proliferative diabetic retinopathy. So, what did the study find? The study found that Lucentis-treated group, shown on the dotted line on the slide, at 2 years, at 104 weeks, there was an improvement of 2.8 letters compared to baseline. How about the laser group? The PRP group improved only 0.2 letters, or nearly same as the baseline. And the difference between the two groups, the PRP group and the Lucentis group, were within 5 letters. So the endpoint of showing that using anti-VEGF therapy for management of proliferative diabetic retinopathy is not inferior to the current standard of therapy, the proliferative diabetic retinopathy, pan-retinal photocoagulation, has been met. Furthermore, the study found that treatment with anti-VEGF such as Lucentis had less damage to the peripheral vision, such that Lucentis group on average lost only 23 decibels on visual field testing, whereas PRP group lost 422 decibels. And this difference between the two groups were statistically significant. As for safety, injection with anti-VEGF agent Lucentis did not show any increase in complications such as retinal detachment, development of new blood vessels such that neovascular glaucoma occurring, or iris neovascularization occurring, or bleeding in the eye or vitreous hemorrhage occurring compared to the PRP group. Interestingly, the Lucentis group had far less number of vitrectomy surgeries needed compared to the laser group, 4% in the Lucentis group compared to the PRP group. So there may be an additional benefit of using Lucentis for proliferative diabetic retinopathy versus pen photocoagulation. So in summary, what did we learn from Protocol S, which was for proliferative diabetic retinopathy management? We found that treatment with intravitreal anti-VEGF agent was not worse than pan-retinal photocoagulation for vision outcome at 2 years. Furthermore, there was superior mean visual field outcomes, meaning the anti-VEGF therapy did not cause more visual field defects compared to the PRP. And there was also decreased need for vitrectomy surgery. So, anti-VEGF treatment may reduce the need for disruptive treatment such as pan-retinal photocoagulation. So in summary then, we are now entering a new era of diabetic retinopathy treatment. In the 70s and 80s, we learned that laser photocoagulation can be helpful in preventing vision loss due to diabetic macular edema and proliferative diabetic retinopathy. Over the last decade, many of these exciting new clinical trials and innovations have developed such that now we can improve vision in patients with diabetic macular edema much more than we were able to do with focal grade laser treatment by utilizing these anti-VEGF agents. Now, anti-VEGF agents do have side effects, such as possible increase in risk of retinal detachment or intraocular infection called endophthalmitis. And also, injections may need to be performed every 4 weeks initially for a number of visits. So I would say for patients with proliferative diabetic retinopathy who will require at least 6 injections that are performed monthly with anti-VEGF agents, if the patient says they cannot come in that often, we may still perform pan-retinal photocoagulation. However, in an ideal patient who are willing to spare their peripheral vision and are willing to come in monthly for anti-VEGF agents to initially stabilize that proliferative diabetic retinopathy, anti-VEGF agents may be considered before trying the pan-retinal photocoagulation for management of proliferative diabetic retinopathy. So these are exciting times. We now have more than one treatment armamentarium under our belt for improving vision and saving vision in our patients with diabetes. We can still perform laser photocoagulation as needed, but in many cases, especially for management of diabetic macular edema, first-line therapy will be utilizing one of these anti-VEGF agents. And for proliferative diabetic retinopathy, based on the patients and their needs, we can consider either pan-retinal photocoagulation or starting with anti-VEGF therapy intravitreally, followed by photocoagulation with pan-retinal photocoagulation as needed. Thank you for your attention.
Great. Thank you so much, Judy, and thank you, Emily, for the great overview. And it's very comprehensive, and I know there's a lot taken. But one of the things I think is really important to stress is that, newer treatments mean better outcomes, and I say we have a lot of work to do because we know that only half of people with diabetes get an annual comprehensive dilated eye exam, which is recommended to detect diabetic eye disease early. So, people do not need to go blind or lose a lot of vision from diabetes, and I think this is something really important for us to stress, that early detection and treatment are really key to preventing vision loss. And I wanted to talk a little bit about some of the educational resources we have available because everyone working with people with diabetes can play a role in their eye health education and preventing vision loss. So what can you do? Educate people about diabetic retinopathy and the importance of diabetes control, and encourage people with diabetes to get the dilated eye exam every year and also keep their health on track. Track is a message that the National Eye Health Education Program stresses through a lot of our diabetic eye disease messaging, talking about the importance of taking medications as prescribed by a healthcare provider, reaching and maintaining a healthy weight, adding physical activity to the daily routines, controlling their A1Cs, blood pressure, and cholesterol. We know that's important from what Emily had discussed earlier. And then kicking the smoking habit. So our diabetic eye disease program is really designed to help raise awareness about diabetic eye disease and the importance of having that dilated eye exam. A lot of our program materials stress that diabetic eye disease often has no early warning signs or symptoms, that early detection, timely treatment, and appropriate follow-up care can prevent up to 95% of vision loss. And again, people need to have an eye exam at least once a year. And I think it's really important to hold no symptoms in the early stages is something we really need to tell people, because a lot of times people are often waiting till they're getting symptoms to see an eye care provider, and that's often a time when treatment couldn't be as effective as it was if people were diagnosed earlier. So where can you find a lot of our materials? Our website is here, www.nei.nih.gov/NEHEP for those of you who are just listening in right now. And we have a lot of educational resources to the patients and with those in your community. So if you're doing diabetes self-management programs, if you're working in communities, or if you have educational resources in your clinic, it's a nice opportunity to share information. This slide just shows kind of a collection of what the National Eye Institute and the NEHEP program offer. We have booklets that you can download and give to patients what you should know about diabetic retinopathy for a patient who's newly diagnosed, and it kind of talks about what diabetic retinopathy is and the treatments available that Judy and Emily had just spoken about. We have a lot of infographics and info cards for those of you who are doing social media. If your clinics and practices have your own Facebook and Twitter feeds, it's a nice opportunity to share some of that information. As far as the tip sheets, we offer tip sheets to health and community professionals to try to tailor information to some of the populations that you're working with. So if you work with a large African American population or a Hispanic or Latino population, how to tailor some of your efforts in terms of outreach to make them a little more culturally and linguistically appropriate, and making sure that you know what resources are available from the NEHEP program to help you. And we also have animations and videos, some really nice ones around diabetic retinopathy, one that talks about how diabetic retinopathy impacts the eye. We have a really unique video that shows what a dilated eye exam looks like from a doctor's point of view, and that's a really nice patient education tool that you can show to your patients to show them this is what I'm looking for when I do a dilated eye exam, and this is what the retina may look like. So we really encourage you to use those resources, and as well as other teaching tools that you can download directly from our website. One new tip sheet that I want to point out that we just released a couple months ago is our Treating Diabetic Retinopathy fact sheet, and it's a really patient-friendly resource that you can print and give to folks. Gives a brief overview of what diabetic retinopathy is, how patients can protect their vision, and it talks about the various treatments that are available related to the various drugs that Judy had just given an overview of, and then it gives them some websites and places that they can go to get additional information. Then I mentioned social media resources, and these are just a few that we offer on diabetic retinopathy, just to encourage people to get an eye exam. So these are, again, all downloadable from our website in the public domain, since we're a federal government agency, so you can take these and use these, and you can add your logos to them as well. Our contact information is here, and I also invite you to join us on our social media networks, where we're putting out a lot of educational information that you're welcome to share with the folks in your community and the patients that you see. So some of the questions that we have, Judy, there's a question about, is there a group of patients that benefit the most from anti-VEGF therapies?
So currently the group that benefits the most are those with diabetic macular edema that shows swelling right at the center of the retina and are quite thickened on based on OCT. And when they're given anti-VEGF agents, it's pretty remarkable how well many of them can decrease the thickness and improve vision in many cases.
Great, thank you. So Emily, this is a question for you. Any ideas on why the increased deaths in the intensive glycemic control group of the study that you spoke of earlier, were they hypoglycemia related? What benefits were seen with lipid control? What benefits were seen with blood pressure control? And what about intensive control of all three parameters?
So this question points to the ACCORD study, the Action to Control Cardiovascular Risk and Diabetes. We had an actually premature closing of the glycemic arm of the study because there were more deaths in the patients who were put in intensive group. It was not a huge number. It was a 20% increase. The number itself was small, but we never could understand why that was. We looked at hypoglycemia. That was not the reason. Looked at different drugs, looking at their comorbidities, such as their heart disease. We really did not find a reason as to why there were more. In terms of the cardiovascular, this study was designed to look at heart outcomes, looking at heart attacks, strokes, and other things. And we found that the blood pressure control was important in reducing stroke, but overall the heart disease was not reduced at all by any of the three arms. And the eyes was the main thing in which there was some effect from the glycemia as well as the phenofibrate.
Now, can I also go back to my first question about which group benefits the most? I want to stress the point that you were pointing out, that the eyes that were found to have macular edema recently, they are the ones that benefit, and therefore it's very important that we identify eyes with disease earlier rather than later, because if the macular edema has been quite chronic of long duration, they may not respond as well. The OCT may improve, but the vision may not improve. Also, even if the vision is poor at baseline, if the disease was found early enough, then they will also improve vision. But if the vision is poor and it's been chronic disease, then they don't respond as well either. So again, I want to stress the early detection of diabetic macular edema and retinopathy with annual eye checkup.
Great, thanks. This question I'll give to Emily. What is the role for nutritional interventions, if relevant, for people with diabetes to control diabetic retinopathy?
We don't have any clear data suggesting that it's important, but obviously you have to eat well and have a balanced diet. And keeping your weight in a normal fashion, both with diet and physical exercise, is very important. The diabetes prevention programs show that just losing weight can be very important in reducing the risk of developing diabetes. So although we don't have anything to suggest that, having certain vitamins or certain food will be important, but we do know that it is important to have a good balanced diet. And we know from the heart point of view that eating fish twice a week is good for your heart. So people who have diabetes have a 3 to 4 time increased risk of cardiovascular disease. So it's very important to have a good heart-healthy diet as well, too.
Great, thank you. Since we're out of time, again, I would like to thank Drs. Chu and Kim for their time. Thank you, and please feel free to contact with any questions.